Okay, colleagues, let's continue. Our next point on our agenda is the hearing entitled Brain Health Policy Challenges and Opportunities to Manage Neurological Diseases. Neurological diseases are one of Europe's most urgent and rapidly expanding health, social and economic challenges. Being the leading cause of disability, neurological diseases are said to affect 1 in 3 people in Europe. This challenges healthcare systems, social support structures and caregivers. Furthermore, neurodegenerative conditions such as dementia, Parkinson's disease and ALS are estimated to increase in an aging society. For instance, Alzheimer's disease is the most common cause of dementia, while Parkinson's disease is the fastest growing neurological disorder worldwide. ALS, through rare, is severe and progressive with rising prevalence. Today we will discuss brain health, an important public health issue. We will address scientific and technological developments in this field and policy options to manage the growing economic and societal burden of neurological disease. To discuss this, we have invited leading experts from the academia and non-governmental organizations. A warm welcome to all speakers. We have a photographer to take pictures of the panelists for the first half an hour. We start this public hearing with a presentation of a briefing entitled Strengthening Brain Health Policy Recommendation to Tackle the Rising Burden of Neurological Diseases, drafted upon the request of our internal research service, the Policy Department, specifically to support this hearing. Professor Ellie M. Hull is the author of this briefing together with Jeroen Pasterkamp. Professor Hall is Professor Ellie Hall, Vice Dean of Research at UMC Utrecht, neuroscientist and Professor of Glia Biology of Brain Disease. Professor Hall, the floor is yours for 8 minutes, please.
Thank you, Mr. Chairman. Dear members of the European Parliament, thank you for the opportunity to speak to you today about a topic that affects us all, the health of our brains. My name is Ellie Hol. I'm Professor of Neuroscience at the University Medical Center Utrecht, and together with my colleague Jeroen Pasterkamp, we recently wrote an expert briefing on neurological health. We are both researchers, and we study how brain disease develop and how we can prevent, delay or treat them. Today, I want to highlight why neurological health requires urgent, coordinated action at the European level, and what concrete steps can be taken to strengthen neurological health in Europe. Next slide, please. Neurological disorders are one of the fastest growing health challenges in Europe. Today, 1 in 3 people live with a neurological condition, which means that more and more people becoming dependent on caregivers. And the economic impact is large, around 368 billion euros per year in Europe. And more than half of these costs are related to informal care. This means that family members, often women of working age, having to reduce or leave their jobs to care for loved ones. The rise in neurological diseases is driven by aging. Therefore, this picture of this aging woman is driven by aging, but also by our genes, but also by our lifestyle choices, such as an active lifestyle or healthy eating, and environmental exposures, such as air pollution or toxic substances. Aging plays a particularly important role. Many of these diseases begin slowly, and long before the symptoms appear, there are already things going wrong in the brains, and this becomes noticeable only later in life. That's why prevention and delaying onset are so crucial. Because these conditions are chronic and progressive, the pressure on healthcare systems and informal caregivers will only intensify unless we act now. And we start with a European health plan dedicated to neurological health. Can I have next slide, please? So let me briefly outline 3 major neurodegenerative diseases. On the left side, you see an example of an Alzheimer's disease brain. The brain on the bottom is of a healthy person that, of course, died because this is post-mortem, but did not have a neurological disorder. The brain on the top is of an Alzheimer's patient. It's very clear that this brain is smaller, so it shrunk a lot. It's also much lighter, and this is because that many cells died in the brain. The majority of patients that get Alzheimer's disease are over 65 years of age, and over the age of 80, almost 1/3 of all people and in that category are living with dementia. To the right side, it's Parkinson's disease. That is the fastest growing neurological disorder worldwide. In this disease, people have often a tremor or stiffness, causes sleep problems, anxiety, and in some cases dementia. It's caused by a loss of a very specific neuron, a dopamine neuron, in a very specific brain area, which is also depicted on the top right picture. And this is also an aging disorder. But in 1 out of 10 patients, the disease started already before the age of 50. Then the last disease is ALS, so amyotrophic lateral sclerosis. This is a less common disorder, but very devastating neuromuscular disorder. Most people that have this disorder die within 3 years after diagnosis. The patients progressively lose all voluntary muscle control, including breathing. As in other neurodegenerative diseases, also in ALS, you see a buildup of toxic proteins. Can I have a next click? So those diseases are all different, but if you look through the microscope, what you see here is a few examples of aggregates of proteins, so protein clumps. And therefore, we think that, we know that progress that we made scientifically in one of these disease areas is a big help for the other disease areas, because there are common mechanisms going wrong in the brain. And I forgot to mention that Alzheimer's disease is the most common form of dementia. So people talk about dementia, most often that's Alzheimer's disease, but there are many more mixed forms. Next slide, please. What I would like to draw your attention to is about dementia, and this is a website. So on the right side you see a QR code which goes to the website of Alzheimer Europe and directly goes to an interactive website where you can search for your specific country what the number and the prevalence is of dementia persons living with dementia, in that country. So these are the numbers of 2025. So on the left side, you see the prevalences in blue. The lighter the blue, the lower the incidence is for people with dementia living in those countries. If you give me another click, then we see on the right side, that's 2050. I'm sorry about the change in the numbers. But in 25 years, we expect that the number massively increase. So today, there are 9.1 million citizens in Europe living with dementia. In 2050, it will be over 14 million. The largest increase will be in people over 80 years. Can I have the next slide? So this is all from the recent Alzheimer Europe report. And this is a very complex slide, but what you see are different age categories, starting from 20 to 30 up to over 90 on the right. And each column is, the lighter blue are the women, and the darker blue are the men. And these are different years. So the first column is always 2025, and the last column is 2050. And then you see, for instance, in the age group over 80 and over 90, which are both on the right, that the number of these people living with dementia will dramatically increase. And that will go up to 19 million in total. Can I have the next slide, please? So, neurological health is a concern to us all, but for me it's also very personal. What you see here, my mother, she passed away 2 months ago, and she lived with dementia during the last years of her life. She was a very strong and independent woman, and it was devastating to see how she lost herself. When she eventually moved to a nursing home, it brought my sisters and me and my brother some relief because we knew that she was safe. She also still remembered, although she had dementia, that I was studying Alzheimer's disease, and she always told me to hurry up and find a cure. But unfortunately, I could not help her because it's not easy to find a cure. But it motivates me even more now to act now. The good news is that we can make a difference. I think neurological health is indeed a concern to us all, and we can. It's not only shaped by our genes, but also shaped by our lifestyle, by our education, social connections, and environmental factors. So prevention is very important, and hopefully this can delay the onset of the disease by a few years. And even a few years can make a huge difference to someone's independence at a later stage in life. In addition, we must strengthen the support system in Europe for formal and informal care, as many Europeans today rely now on unpaid care from family members, and often also the women of working age. I think that's very important to do. And finally, we must enable innovation. We are seeing important medical advances, and the first disease-modifying treatments for Alzheimer's and for ALS are emerging. They are not cures, but they slow the disease progression. And to benefit patients, however, health systems must be prepared to also diagnose earlier, deliver complex treatments safely, and make them accessible. Next slide, please. Also, the scientific opportunities are growing rapidly, and this is a nice picture from my research, so it's also personal input. And in my work, but also in other work of people in my department, we use a lot of human postmortem brain tissue of people that donated their brains for research and for science. But we also make a lot of use of human-based cell models, which are in the bottom of the picture. We also call them NAMs, or New Approach Methodologies. These are, for instance, so-called organoids or mini-brains. So we can make mini organs for many parts of our bodies. And they are made from patient stem cells. So to study disease so this is very important to study disease mechanisms and to test potential treatments more precisely for specific people. We also have a lot of large data sets, or omics. So this is this plot with all these dots. And we're producing daily many of these data sets, and this will lead to new targets for therapy. So advances in brain imaging and diagnostic monitoring and also neurotechnology are also opening new doors as well. To fully benefit from all these developments, we need strong European collaboration. We need good data infrastructures. We need shared standards and close partnerships between academia, biotech, and industry. Next slide, please. That's why we propose that it's time for a European neurological health plan based on 4 priorities. First, promote prevention across the lifespan and integrate neurological health into public health, environmental and education policies. Raise awareness of risks such as inactivity, poor diet, air pollution and pesticides. Second, reduce inequalities in access to care. Today, access to specialists, biomarkers, therapies varies widely across Europe. We recommend minimum EU standards for neurological care pathways and stronger support for informal caregivers, including flexible working arrangements and trainings. 3, invest in early detection, biomarkers and innovative diagnostics. So earlier diagnosis is essential, especially as new disease-modifying therapies emerge. The EU should expand research infrastructure to harmonize data sharing and support equitable access to advanced diagnostics, from neuroimaging to digital tools. And finally, accelerate research innovation and translation into therapies, and strengthen the European pipeline for scientific discovery to real treatments, including advanced technologies such as gene therapy and using new approach methodologies such as organoid-based cell models for testing and research. In research with data and tissue of patients, for instance, clinical data, but also genetics, but also these organoids from patient cells, data protection is key. However, the rules of the EU General Data Protection Regulation can be sometimes experienced as an obstacle. Final slide, please. In conclusion, neurological disease are among the biggest health challenge of our time. Postponing the onset of the disease or delaying the progression will have a major impact on the independence of the elderly generation. The science is advancing rapidly, and with coordinated European action, we can transform the lives of many Europeans, patients, caregivers, and future generations. I would like to thank also Alzheimer Europe and Parkinson's Europe, who gave a lot of input for our expert review, and also my colleague Jeroen Passekamp for working together on this with me. And thank you very much for your attention.
Thank you, Professor Hall, for your great work and inspiring presentation today. Dear colleagues, we will now move directly to the two panels of this public hearing. Each panel is followed by a round of coordinators' remarks and catch the eye. Then I will give the experts the floor to react to members' remarks and questions. We begin with the first. Yes, we need a moment to rearrange the podium. With the, they can come up, the two first speakers. And I'd like to ask our guest to join us, Mr. Professor Ząbek and Anna Verdelho, Professor Anna Verdelho.
Yes, but I have to go. Yes, if you want me to sit here, no, you would get the floor because they will come up here. So yes.
Thank you. Thank you, Professor. Okay, we begin with the first panel on success and challenges of cutting-edge research on neurology and the potential of neurotechnology. I would like to welcome Mirosław Ząbek, Professor, Head of the Neurosurgery Clinic at Mazowiecki-Brudnowski Hospital in Warsaw, and Anna Verdelho, neurologist in the Department of Neurosciences of Santa Maria Hospital in Lisbon. He's also professor at the Medical School of the University of Lisbon. I invite colleagues who would like to take the floor during the Catch the Eye to indicate it to me and the Secretariat. I would like now to give the floor to our first speaker, Professor Anna Verdelho, for 8 minutes. The title of her intervention is Neurocognitive Disorders, Is It Possible to Prevent? The floor is yours, please.
Thank you. Dear members of the Parliament, it is an honor to be here today. And as a neurologist specially dedicated to cognitive disorders and dementia, I thank you for taking the time to hear my concerns and my thoughts. I would like to give you some key points, and I hope to leave you also with hopeful ideas. Next slide, please. Along with the aging of the global population, we are facing a steeply increase in the number of people that is living with neurological disorders and mainly with cognitive impairment and dementia. My first key idea is that we know now that neurodegenerative disorders probably result from the combination of factors through aging, and all research supports that an agent that only alters a single aspect will not have an impact. Next slide, please. On that sense, and knowing that 45% of dementia cases can be attributed to 14 potentially modifiable risk factors, we urgently need to increase efficient measures to promote prevention. And I'm speaking about very well-known risk factors: hypertension, diabetes, hyperlipidemia, sedentarism, obesity, but also other modifiable factors as education, as brain trauma, as pollution even. So prevention needs to be done in any life moment. As you can see in this schematic graphic of the Lancet Commission, the risk factors start very early in life. So implementing prevention strategies need to cover all moments of the life of an individual. Next slide, please. Following the growing body of information on risk factors and on the evolution of the numbers of dementia, the World Health Organization promoted for the first time a guideline with recommendations for the risk reduction of cognitive decline and dementia. Although they were published 7 years ago, it is an utmost important document, very easy reading, and it includes most of the risk factors that we need to control. Next slide, please. The second idea I want to leave you is that there is a very hopeful information. We heard just before the evolution of the numbers of dementia over Europe. But what I can tell you is that while there is no curative therapy for any of the degenerative dementias, we have data supporting there is a decrease in incidence, meaning new cases for a time frame, in several points of the globe. So you can see in your left side, you have aggregated data from 11 cohort studies from both Europe and from the United States that analyzed more than 50,000 people. And what they found is that, in fact, over the last 20 years, there was a consistent reduction in 30% per decade in the new cases of dementia for some countries, for some age groups, for some sex groups. And in the right side, you can see from 3 cohorts from Sweden that aggregated more than 1,000 people over 80 years of age. You can see that the same result was found. They were born in 3 different decades, and over the 3 decades, there was a reduction in the new cases. And this study approached also the total cases, so meaning the new and the existing cases. And they find also a diminished result in the existing cases for people older than 80 years old. So it seems that last decades, with better economic status, with better education, with better access to medical treatments, has done a result. Next slide, please. But it is important to note that this downward trend may be not last, as it was pointed by the English study of aging that analyzed trends in more than 20,000 people. And they found that after a decline in incidence, so the new cases, there was a U-shaped curve recovering again. So the authors warned that probably the result of the modern life, more time behind screens, more sedentary time, more perhaps mental problems, more addictive problems, may change the good tendency. So the reduction in incidence is not like something we won, it's something that we need to fight for. So next slide, please. My last idea I would like to leave you is concerning the public perception. Because we might have a problem in what the public thinks about what are the risk factors, what wants to fight for. So because if we don't have people sensitized to a better way of dealing with life and risk factors, we are not going to change attitudes. So again, we have studies from different parts of the world, and the responders ask the question, what are the factors that are important for my risk for cognitive decline in dementia? And in fact, people recognize the genetic heritage and aging as the most relevant risk factors, and they don't consider the impact of vascular risk factors as what I mentioned, hypertension, diabetes. As you can see in this Irish study in your right side, more than half of the responders were against thinking that controlling hypertension or diabetes could prevent dementia. And I should notice that the higher level of education of the responders was preventive, was associated with a better health literacy. So next slide, please. There are already instruments which identifies concrete actions that can be to implement better health control and better rules for controlling health in general. So the instruments are there, as this Be Mobile, Be Healthy from the World Organization with the ITU. So the instruments are there. So my last slide, please. So I would like to say that to end that prevention is desirable, is achievable. It is not expected that any revolutionary change in science will cure dementia, but health policies can do, or is doing. We are already arriving that. So we need urgently to change our attitudes. So any type of actions needs to be transversal to all intervenients and must be multimodal to use different approaches. And at last, we need that citizens are involved, are empowered, need to understand that they become also actives in preventing. Thank you for your attention.
Thank you, Professor Verdelho. I will now give the floor to Professor Ząbek. Professor Ząbek is specialized in neurosurgery and neurotraumatology. He's the head of Department of Neurosurgery and Injuries of the Nervous System of Postgraduate Medical Education Center at Mazowiecki Hospital in Brudno. He will speak about the brain gene therapy. Professor Ząbek was the first in Europe to apply this technique clinically and able to perform it in a large number of patients. Professor, the floor is yours, please.
Mr. Chairman, honored chairs, dear member of Parliament, it's really a very great honor for me to be here with you, to be here on the stage in European Parliament. So thank you very much for the invitation. I was invited here to share with you my experience, unique experience, and I think very promising experience in brain surgery, especially in gene brain therapy. Next slide, please. Many years ago, I introduced in Europe the kind of surgery, the surgery in the real time of a magnetic field. What does it mean? That means that the surgery is performed not in the operating theater, but in the gantry of magnetic resonance device. This technique enables us to observe in a real time what is going on in the brain. We see the tip of a needle. We can observe distribution throughout the brain of injected viral vectors. This was the beginning of gene therapy in Europe, and I also was the first who introduced this kind of surgery in Europe. Please, next one. There are two mechanisms of gene therapy action. We can introduce the copy of the missing gene in the brain, or we can introduce the gene which will block the function of wrong gene which produce pathological harmful protein for the brain. Next one, please. There are two types of gene therapy. germinal, that means manipulation of gametes. From the ethical point of view, it's prohibited. And it's also somatic gene therapy. This refers to all body cells except gametes. Next one, please. Our achievement. We are the leading center in Europe in gene therapy. We, as a first in the world, performed gene therapy in multiple system atrophy, is very horrifying neurological disorders. Also, as a first in the world, frontotemporal dementia. It's popularly called Bruce Willis disease. As a first in Europe, we performed the surgery, gene surgery in Huntington disease, Parkinson disease, and AADC deficiency syndrome. About this pathology, I will tell just a moment later. Now we have received the grant from European Union for the treatment using gene therapy, Alzheimer's disease and Parkinson's disease. How it is important? It's suffice to say that from Alzheimer's disease in Europe are suffering about 10-12 million people, and from Parkinson's disease are suffering in Europe about 1.5 million people. Please, next one. Please click the same slide again. AADC deficiency is the horrifying disease. The children suffering from this disease usually die with the first or second decades of life. All the children are like this baby on the slide. It's congenital disease, and the reason of this disease is the lack of one gene in brain, which is called aminoaromatic decarboxylase, which this enzyme is needed to produce dopamine and serotonin. Please, next one. And next one. During the surgery, we introduce the copy of missing gene to the very crucial to a very crucial part of the brain, to a brainstem, to substantia nigra, and this gene is distributed via regular physiological transplantation, neuronal transportation. Next one, please. We have operated on very many children from all over the world, including America and Canada. Next one. This is the child from. This is a girl from Canada, still at home. Can be louder the voice sound.
Do you like Poland? Yeah.
This is the girl before coming to us to Warsaw for the treatment. Next one, please.
Yeah.
Next slide, please. During the surgery, in very precise procedure lasting many hours, were introduced to the brainstem, to substantia nigra, a very small amount of viral vectors, about 500 microliters. But we change completely the life of such a child. The child usually reborn again. Next one, please. Next, please. This is the same girl, a few months after the surgery. Now she's in Canada.
Ready? 1, 2.
Next one, please. The following months after the surgery. As a light slide, I would like to present you a very short film, 3 minutes, 5 minutes, to describe in short the history of this child. Once again, please, click.
Our daughter Ryan was born with a rare
And the voice louder.
deficiency. This is the story of how gene therapy has given her a second chance at life. Living with AADC meant that Ryan couldn't move. She never reached any physical milestones, and the only thing she had control over was her smile, which was her one way to communicate with us. Ryan couldn't stand on her own, sit on her own, or even hold her head up. She needed full body support at all times and couldn't even use her hands to play. Ryan was so weak and dismayed that she spent most of her life either sleeping, regardless of where we were, or crying, even during happy celebrations. She was so medically fragile that even catching a simple cold would land us in the hospital, often pushing her little body to its absolute limits. Ryan never gained the ability to eat or drink and relied on a feeding tube. Every 2 to 3 days, she would have painful seizure-like spells called OGCs, which made her body stiff and her eyes roll to the back of her head. An OGC could last anywhere from 4 to 8 hours. Watching her suffer so terribly for nearly 5 years was heartbreaking, but we never lost faith that our miracle would come. And it did. We flew to Warsaw, Poland, and I laid Ryan down on the operating table. On September 3rd, 2019, she received gene therapy. This was the day that my daughter was reborn. Ryan had her last OGC ever on the plane ride home from Poland. And then...
Ryan, you're holding your head up.
Head control. Then came using her hands to play. And then eating. Followed by drinking. And learning how to sit independently. It seemed as if we traded all of our past days at the hospital in for new days of therapy, getting stronger and learning more every day. From being so frail that she wasn't even on the growth chart, to becoming 58th percentile 6 months after surgery. From being held like a newborn, to learning how to stand independently. From being tube-fed, to eating Happy Meals. From needing full support, to learning how to support herself. Standing, playing, learning. Ryan entered a whole new world. From only ever being able to taste a small amount of icing from her birthday cakes, to eating as much as she wants and feeding herself.
I think that gene therapy is really the future in the medicine, not only in neurosurgery, but probably in another kinds of specialization. Thank you for your attention.
Thank you, Professor. Very impressive presentation. It's good to see the success in treatment of neurological diseases. Now I open the floor to our colleague MEP, and we're starting with Tomisław Sokol as the first, please.
Thank you, Chair. Thank you for being with us and presenting also some successes and positive stories, which is always good to see that actually what we are investing in health and everything that that health science is doing is actually bringing some results. So I would like to congratulate you for that. The topic of brain health is unfortunately a pretty neglected issue here in the European Parliament. We speak a lot about cancer, we speak a lot about cardiovascular diseases, about alcohol, tobacco, the usual things, which are obviously extremely important, but unfortunately brain health is definitely a topic that is not talked about that often, even though it impacts such a big number of people. It's not just that it impacts them, but that it impacts their everyday life in very profound ways, in a way that most other diseases don't. So I think that for that reason, brain diseases and brain health in general should play a much more prominent part in the discussions in the European Parliament, and this is why I'm glad that we have such a hearing here, and that will continue to work also on concrete documents, concrete proposals to actually resolve the topic, to try to make some improvements also on the European level. What was mentioned is that unequal access to treatment is one of the biggest problems in the EU. So we still have first and second class citizens. We still have different medicines that can be accessed in different member states, in different regions, different therapies, and definitely we can speak about having first and second class citizens. So those who are entitled and who have access to the most up-to-date advanced health treatments and those who do not. I have two questions. So first is the question for both of you. What can we do on European level to stimulate and incentivize and make it easier for the development of such highly advanced therapies, new medicines, new treatments, research into most advanced therapies? So what can EU do to actually make this easier? Whether it's more funding, more investments, less red tape, better regulation, more access to cross-border healthcare. So what should be the priorities on the EU level to make access for patients to most advanced treatments easier? And the second question is, what can we do to make this access easier, but also more equal? So what can we do to make it easier for patients across the EU, that all patients have the access to this most advanced therapies and medicines and treatments that are available now in the EU? Thanks.
Thank you. Vitanis, you want to comment?
Thank you, Adam. Thank you very much indeed for your excellent presentation, Professor Mirosław. It's really so nice to see such a brilliant effect. But may I raise two questions? One question is more general. You know that we have a comprehensive approach on mental health, which was published by the European Commission. Now we are discussing, brain health. But from my point of view, brain health and mental health must be united, because generally you see two sides of the same coin. And sometimes, a separation from mental health, from brain health, creates a lot of silo effects and a lot of, challenges, because it prevents us to understand the integrated approach. And we need to now, my question is, do you see possibility to integrate brain health and mental health as one comprehensive strategy? And second issue, you just mentioned Lancet. Lancet probably declared very clear all risk factors which are common to cancer, common to cardiovascular diseases, common. All those risk factors also allow us to understand that we need to send to our colleagues that if you are treating hypertension or treating air diseases, and please keep in mind that you can prevent something in the future, dementia or Alzheimer. It means that we need to see multimodality in this issue. My question is, do you agree that we need to introduce much broader prevention strategies in all specialties, including general practitioners?
Thank you. Margarita de la Pisa-Carrión.
Gracias, presidente. Señorías, bueno, evidentemente nos ha parecido espectacular.
Could you stay for a moment? You
Okay,
need,
I will speak in Spanish. Okay. Thank you.
Sorry, maybe too much. You need. Okay.
Gracias. Me ha parecido espectacular el ejemplo que ha mostrado sobre terapia génica. Soy farmacéutica, experta en biotecnología, y cuando decidí mi especialidad fue justo pensando en situaciones como esta, ¿no? Hoy realmente nos enfrentamos a poderlo hacer realidad. Entiendo que en este caso nos ha mostrado un ejemplo de corrección de una condición congénita, pero igual se puede aplicar, ¿no?, a otras enfermedades que a lo mejor suponen unas alteraciones a lo largo de la vida, ¿no? Querría preguntar también, para la investigación de este tipo de tratamientos, cómo afecta la investigación en modelos animales. podemos prescindir de ellos. Sabemos que en Europa se está empujando por intentar no utilizar modelos no animales, pero probablemente no pueden replicar la complejidad cerebral. ¿Cómo ve este asunto? Porque es verdad que si no invertimos en este tipo de modelos y vemos otros entornos que sí que lo están permitiendo, igual podemos perder esta carrera tan importante de la biotecnología. Por otro lado, otro asunto, la población en la Unión Europea mayor de 65 va a aumentar un 100% en las próximas 2 décadas. Esto, como ha contado usted, es un factor de predisposición importante. ¿Cómo podemos investigar para saber cuáles son los factores que están incidiendo, que son los factores de predisposición? Se escucha que la incidencia de Parkinson ha aumentado muy rápidamente por encima del Alzheimer. Las causas se desconocen, ¿no? Se está asociando al ambiente rural, puede ser un tema de pesticidas. ¿Cómo podemos invertir en descubrir cuáles son estos factores? Ya que la prevención no ofrece una posibilidad de rentabilidad, ¿no? No hablamos de un medicamento, ¿no?, que en un momento dado se pueda poner en el mercado, sino que es la prevención, es una investigación más básica que no es tan fácil que sea apoyada por inversiones privadas. Gracias.
Thank you. Catarina Martins.
Muito obrigada, Sr. Presidente. Queria começar por agradecer as apresentações que foram feitas. Acho que foram muito interessantes e contribuem muito para o nosso trabalho. Queria fazer 2 perguntas muito breves. A primeira para o professor Mirosław. A inovação que nos vem mostrar aqui é muito impressionante, pode impactar muito a vida futura de tantas pessoas. A pergunta que lhe faço é, a nível europeu, o que é que lhe parece que podia ser um contributo para que o seu trabalho estivesse ao alcance de todas as pessoas? Ou seja, a questão do acesso ao que vai sendo feito. À professora Ana Verdelho queria colocar uma outra questão que tem a ver com o impacto tão largo na sociedade de Alzheimer e de outras demências, porque uma vez que está relacionado com o envelhecimento e tem um impacto muito grande nos sistemas de saúde, também nas necessidades de cuidado e, portanto, necessariamente nas famílias que cuidam e, maioritariamente, nas mulheres que cuidam. Fala-nos da prevenção como um caminho de futuro. A prevenção tem de começar décadas antes, bem percebo por aquilo que faz. E, portanto, também lhe perguntar, nesta acessão mais larga de adaptarmos os nossos sistemas de saúde e sistemas de cuidados ao que é a necessidade de tantas pessoas com Alzheimer e demências, e também, claro, de promover a prevenção, se vê uma participação do ponto de vista europeu que possa ajudar a este caminho. Nós sabemos que os sistemas de saúde são nacionais, mas aqui todos acreditamos que a solidariedade também é possível, portanto se vê caminhos nesse...
Thank you. Ignacio Marino.
Thank you. Thank you, Mr. Chair, and congratulations for this wonderful, treatment that you have really realized on this Canadian child. Obviously, it's very, very moving and impressing. I have a simple question. I know that adenovirus could be used to put in the brain different genes, and the procedure is obviously complex, but possible. And I wonder why is not used more often with disease like Parkinson's disease and motor neuron disease, because obviously you can teach us this disease can be treated as well with adenovirus gene injection in the brain. And my question is just because of shortage of money or shortage of centers that are studying this kind of technology, or there are any other reasons?
Thank you. Ignacy Romana Jerkowicz.
Thank you, Chair. And thanks to our speakers for excellent, interesting presentation. You know, there are really impressive advances in neuroscience and neurotechnology, and we were just witnessing that. But in many cases, from the policy perspective, the real challenge is translating that innovation into real life, into the practice. And here I'm talking about early detection and early diagnosis, because Europe is still diagnosing many neurological conditions far too late, when the window for an intervention is already closing. So why is there still such a gap between between research and clinical implementation across the EU? How can we improve translation from, lab discoveries to a patient access? And what about Horizon Europe and the EU for Health funding? I mean, it doesn't seem to be very much aligned with the real socioeconomic burden of these diseases. Thank you.
Thank you. And last question, Laurent Castillo, please.
Merci, Monsieur le Président. Merci à vous deux pour ces présentations. Et je m'adresserai un peu plus à Madame Verdelho. Madame, vos travaux ont montré le rôle majeur des facteurs cardiovasculaires dans le déclin cognitif. En tant que professeur d'ORL, je voudrais vous interroger sur un levier que vous n'avez pas évoqué, qui est sans doute méconnu, l'audition. La perte auditive liée à l'âge est très fréquente et elle s'accompagne souvent d'un isolement social, de dépression et d'une moindre adhésion aux soins. Vous avez évoqué les méta-analyses, les études de cohorte qui associent une plus grande fréquence des démences lorsqu'il n'existait pas de correction auditive. Vous avez évoqué également un essai randomisé qui a été publié dans le Lancet qui montre que l'utilisation d'une audioprothèse préviendrait l'évolution vers des démences. Alors dans ce contexte, ma question est quelle place donneriez-vous au niveau européen au dépistage auditif, à l'accès précoce aux audioprothèses dans une stratégie de prévention du déclin cognitif en complément, bien évidemment, de la prévention cardiovasculaire. Je vous remercie.
Thank you, colleagues. Now I would like to ask our expert to answer the questions. Professor Verdelho, could you start?
Okay. So starting
5 minutes per person.
Okay.
I can limit.
Okay. So if I can start with you, you are correct. I did not list all causes. And yes, you are correct. Auditive ability as well as to see is important. But they are listed in those. I didn't just said all the risk factors that are there. I did not list them. They are there. But you are correct. And we need to implement that early in life because not only older people have difficulties and they get restrictions in social interactions because of not hearing or not seeing, but in childhood, they don't learn enough if they don't hear and they don't see. So exactly the same, and you are correct, we need to implement better system to do it. Fortunately, in Portugal, we do it. We do it systematically, and we can do it to all. I would say something that I think that many of you asked, that is one of the answers I could give to many of you is that I need that the citizens be more educated on the sense of knowing what are the risks for themselves. So they need to know what they are going to gain to invest in own health. And I think it's our job as health professionals to teach that. And I think this is a good initiative to do a plan to better reach each person in the good information they need to have to make better for his own. So getting back again, here you ask about the gap between the investigation that we have from the Europeans like Horizon, and I think the problem is that we have many trials on the cell, on lab, on the animal, but we don't have enough trials trying to translate these findings to the person and to the real environment. And we need that. There's a call now that was open in Portugal that really is to implement our findings for our academical research in the community. And this is a very good idea, and I think we need more of that. How to implement what we find from research in the usual places where people live. And I think that is going more far away than primary care, is start in school education. I think we need to implement better health literacy, starting very early in life, as you pointed out before. And I think it's really important to consider that we are a continuum from birth. Probably pre-birth factors are as important as well. And we know that if you have a birth more healthy, you will have a life more healthy, and you need it to do overall life. And someone asked me about why I insisted in prevention. I think it was from this side, why I insisted in prevention. Because after 30 years working in the dementia field, and it's a failure and failure and failure in each trial. And we try, and we don't have, for more than 25 years, we don't have any new drug, any new good, effective drug that we can say it's effective, it's going to change in the field of dementia. And this is why we need to change a little bit our view, and it took, for me, 30 years to rethink a little bit. I think you asked me here about mental health and brain health, and you are right. It's an artificial difference. Of course, it's something like mental health is more from the psychiatry field, brain health is more from the neurological field, but yes, we depend each other, we work very well together, and of course that depression is a risk factor for dementia, and if you have cognitive problems, you have a higher risk for depression, so they are mixed. It's kind of artificial, but we need to work them together. Somehow, mental health has gained more impact, brain health is a little bit behind, and we are taking more time. And I think that the reason is because we are not reaching very good results. We are having for some specific disease, and we are have it in big, large data that we put together. And I would like to stress that I think Europe is very good working together. We have a very, very good experience in doing studies with other countries in Europe, and we can manage to find a way. And I think we can be successful, but we need trials very well designed with very good objectives and with a high ethical standard. And I think I'm...
Thank you, Professor Verdelho. Professor Ząbek, could you comment the question, please?
Thank you for your question. I'm very sorry I don't remember your name, the member of the parliament, so I will start answering from the last question. And all this question was close to each other, very similar, so sometimes maybe in my answer will be answered to many questions. What to do to the last question, what to do to make the diagnosis very early? For the time being, it's possible to make the diagnosis before the symptoms occur. So the patient must present clinical symptoms, and maybe and in that moment it's possible to make the diagnosis. Sometimes it's not so easy. For instance, tremor. Tremor is a very important symptom in many diseases. Essential tremor, Parkinson's disease, Parkinsonian plus, and many other neurological and neurodegenerative disease. So we have sometimes perform very rare radioisotopic investigation to set up the diagnosis. Referring to adenovirus, yes, in all trials we use adeno-associated virus, but of course, adeno-associated virus is only the part of nucleic acid, but this part of nucleic acid is the only messenger who carry the active substance. Of course, it's possible to produce maybe not everything, but for the treatment of Parkinson, and this is still clinical trial. It's really very beginning. The group cohort observed and treated, it's 2016, 15, 8, so it's very small group. The treatment is really very sophisticated, very difficult. It's only few centers in Europe were the first. The treatment is extremely expensive. The gene therapy, which is registered and reimbursement, is at least €2 million for one patient. But what is good in such a treatment, that the treatment is given only once a life. It's not necessary to repeat. So, for the time being, this treatment is not very popular. It's the beginning, but everything have to start in moment. You ask about the pathology congenitive, but there are, of course, the disease which are occurred not from the delivering, but in some part of the brain. What we do now, we are working and treating the patient, really very small group, Parkinson's disease, Huntington disease, multiple system atrophy, AADC deficiency syndrome, and mild form of cognitive disorders. It's Alzheimer's disease. This year, in the end, we will start the treatment of Alzheimer's disease, but in this case, we will not use adeno-associated virus, but we use trophic substance which will renew the damaged structure in the brain. But I again would like to say that it's really very beginning, and the treatment is the surgery for one patient lasts 10-12 hours. The personnel which is acting during such a surgery is about 20, 23, 25 persons. So it's for a long time will be not very popular, the treatment. But we are trying to make shorten the surgery and cheaper the surgery. And I think that we will be able to operate 3 patients a day, not one for 12 hours.
Thank you, Professor. Thank you, Professor Verdelho. Thank you for your time and a very impressive presentation. We are keeping fingers crossed for your research and successful treatment for our patients. Thank you all for a meaningful discussion on the first panel. And let's go further to the second one. Thank you very much. Okay, colleagues, welcome for the second panel on European collaboration on neurological health, in particular in the field of dementia and other neurodegenerative diseases. For this panel, we welcome Professor Sameer Zuberi. He is President-elect of the European Brain Council and past President of the European Pediatric Neurology Society. Let us also welcome Dr. Orla Galvin, Executive Director of the European Federation of Neurological Associations, which is an organization that represents the neurology patient voice in Europe and acts at the interface of research, innovation, policy and regulation. As for the first panel, I invite colleagues who would like to take the floor to indicate us. Now I would like to give the floor to our first speaker of the second panel, Dr. Galvin. You have the floor for 8 minutes, please.
Thank you for the invitation to share the insight from the patient voice across Europe today. So for those of you maybe entering the room who don't know, neurological conditions affect the brain, central nervous system, peripheral nervous system. So that is everything from the top of your head to the soles of your feet and everywhere in between. And the age of onset can be any time. That really depends on the condition. Throughout the talk, you will see that we are in full support for the recommendations for a European health plan dedicated to neurological conditions as presented by the first speaker today, Professor Dr. Ali Hall. Next slide, please. I will speak more slowly, yes. So today I'm speaking on behalf of EFNA, representing the Neurology Patient Voice, a community centred in collaboration. Some, but not all of our collaborators are referred to on this screen. They include patient groups, clinical groups, researchers, policymakers, and regulators. Each one of these stakeholders, these entities, these partnerships, would benefit immensely in their objectives if we, the citizens of Europe, had a European strategy for neurology. Each partner could deliver more effectively, more expeditiously, to improve the quality of life of people with neurological conditions, while saving each country within the EU some money. Next slide, please. Let's look at the numbers and absorb the data. I'm going to ask you to look to the person to your left and then to the person on your right. And among you, at least 1 in 3 will be affected by a neurological condition. Some of you already know the neurological condition that you have, and some of you are yet to find out. We know that among non-communicable diseases, that neurological conditions account for 13% of the total disability-adjusted life years lost, that they are responsible for 20% of the deaths in Europe, and that annually they cost Europe over €1 trillion. Next slide, please. What we need to do is address some of the data gaps and the knowledge gaps, and patients and caregivers are already willing to do this. So the next number of slides are indicative of the responses of 4,900 people across Europe living with a neurological condition. This slide indicates that we as European citizens absolutely lack neurology-related health literacy. And that has resulted in over 80% of people not being believed when they attend their healthcare professional and not receiving adequate treatment. Because why? Over 50%, 56% of people had difficulty in describing their symptoms. And naturally, this is in part the reason why 2/3 of people are initially misdiagnosed. Next slide, please. On this screen, TI refers to treatment intervention. And you can see in the dark blue, only 1 in 5 people with a neurological condition have the best available, which means they have good access to treatment intervention, they can afford their treatment intervention, and their intervention satisfactorily manages their condition. They have it good, but they're not cured. It's only an intervention. Next slide, please. Behind every patient is a life impacted daily by their neurological condition. We see that 3/4 of people find education very difficult, and in that environment, around half of people cannot make friends or sustain friendships because of their neurological condition. And only a small percentage of educators, 17%, were understanding about this. Next slide, please. Employment challenges are very real. 70% of people had to make some adjustment to their working environment. Only 35% of employers were supportive. And again, 2/3 indicated their neurological condition made their work life more difficult. Next slide, please. Financial anxiety can be crippling. Over 70% of people had higher costs and lower income because of their condition. And 1/3 were denied mortgages or insurances because of this too. Next slide, please. All of this is against the backdrop of stigma. 88% of people living with a neurological condition face stigma regularly. And now I'm going to share some testimonies from 3 patients who kindly were willing to share their insights with you. Behind all of this data are real people. The first is on the next slide. His name is Gary. In 2007, Gary was a successful HR manager with a young family, and he had a sore hand, what he thought was from overuse of the computer mouse. In 2008, he could hardly read his own handwriting. In 2011, he was finally diagnosed with early onset Parkinson's disease, age only 44. He had no idea what this meant for him or his family. And unfortunately, by 2015, his condition had deteriorated so much he had to step down from his job. In his own words, my confidence collapsed, my outlook became foggy, and the future I had taken for granted felt so limited. But Gary is not alone. Next slide, please. This is not Julia. Her name is changed for protection, and the following is the testimony of her parents. In infancy, Julia appeared shocked and disoriented. Her parents didn't know what was happening, just that something was wrong. That was until seizures became so dominant in her life, and after seeing multiple doctors, she received her diagnosis of epilepsy. Despite treatment intervention, family life became that lived on high alert, always preparing for a crisis. Her parents live with constant stress and anxiety, while also grieving the loss of the life she could have had. They say other children playing can be very cruel, and other parents keep their distance too. It's not fair on her or her siblings, but her parents try to maintain a loving, normal as possible family home. Next slide, please. The last person I want to introduce you to, but no means least, is Ines. Ines is a young scientist with a master's in biology and genetics. At age 20, her mother noticed her first symptoms. She was slower, more fatigued, and anxious about everything. At 26, she was diagnosed with Huntington's disease, inherited from her father, who died aged 54. Unfortunately, we will never know the scientific and medical discoveries Ines could have made. Next slide, please. Because within 3 years, Ines required full-time care and is now in late-stage Huntington's disease, is bedridden and without independence. Her mother is age 67 and she cannot retire because she needs the money to take care of Ines. During the week, she has someone to help her, but at night and at weekends, Ines's mother is alone. Next slide, please. All of this is to say that we as a European society very much need some coordination and strategy around a European plan for neurological conditions. A European coordination for neurological conditions is essential precisely because national systems alone cannot close the data gaps, cannot address the treatment and care gaps, and cannot address the financial gaps that every single country is bearing the brunt of. For a European strategy to be effective for people living with neurological conditions, it must include their insight and expertise. Neurological health requires an integrated life course-based approach and not siloed specialities. We talk about prevention, but for many this refers to risk reduction, and it must be understandable, inclusive, and linked to early recognition, not just lifestyle slogans, but impactful health literacy. Thank you for listening today.
Thank you, Dr. Galvin. Now I will give the floor to Professor Zuberi. Please.
I'd like to thank the committee for inviting me to speak today. I am a pediatric neurologist from Scotland, past president of the European Pediatric Neurology Society, and I want to talk about brain health in the broadest sense of neurological disorders and mental health disorders. Next slide, please. The European Brain Council represents professional societies representing more than 250,000 neuroscientists, psychiatrists, adult neurologists, pediatric neurologists, as well as EFNA and Gamian Europe, who are representing millions of EU citizens. Next slide, please. So we've heard about the burden of neurological disorders, the #1 cause of disability, and the #2 leading cause of death. So we need to find solutions for this in Europe. Next slide, please. This is the WHO definition of brain health. Now, when we think about brain health, we should be thinking about mental health and neurological conditions together, because the brain is our key driver of competitiveness, leadership in technology and life sciences, and productivity. We've heard about prevention. We need to have more research support, and we need innovation enabling reforms. And this should be public health, but beyond that. So there's a significant policy overlap between mental health and neurological disease, and the EU has the scale to make a tangible impact. Next slide, please. So we need to be thinking about brain across the life course. The human brain is the most complex structure in the known universe. Now, President Trump may produce something out of the known universe in the next few weeks when he releases all these files from Area 51. But so far, this is the most complex structure. It only runs on 20 watts of power and only 400 calories a day. So we should be investing in the human brain, perhaps much more into these really massive data centers, because the human brain can achieve much more. Next slide, please. The human brain has 100 billion neurons at birth. If you look at the first picture on the top left, the brain is 3 millimeters at 3 weeks of age, 3 millimeters long. And this is how it changes through pregnancy. We have 250,000 nerve cells per minute being produced. Can you imagine that? So the first 1,000 days, pregnancy, and the first 2 years of life is when the brain changes more than at any other time. So if you want to prevent, influence the life course of disease, you really have to be thinking from the beginning of life and even through pregnancy. By 3 years, we've got 100 trillion neurons. 100 trillion connections between our brain cells. After that, we don't get any more connections. What happens? They get pruned. They get modified. And they get modified by our experiences, the life we live. So if we live a traumatic life through childhood, and we have 3 adverse childhood experiences, then we're at very high risk of having mental health problems later on in life. So we prevent mental health problems by making the life of our children better. Next slide, please. So brain health is critical to global well-being and planetary health. So this is how brain health influences the UN Sustainable Development Goals. So we can think about brain health influencing our physical and mental health, social health, and ultimately planetary health. Next slide, please. We've heard some of these facts and figures before about the total disease burden in the EU. 30% can be attributed to brain health conditions. Disability-adjusted life years means a year of life that you lose of good health due to a condition. So this is really important. Next slide, please. So there is an opportunity to intervene, and we should intervene early. Mental disorders, substance use disorders, self-harm, neurological disorders have determinants early on in life. The brain continues to develop and change until you are 25 years of age. And then anyone over 25, we're all getting older now. But before that, you are still developing and growing. And that's the time that we can really make change. Next slide, please. We've heard about rare diseases. 36 million EU citizens are affected by rare diseases. 70% of those affect the brain, and 70% begin in childhood. Now we've heard a lot about dementia of affecting old people, but many of you won't know about early childhood dementia. I'm probably the only person in the room that knew about AADC deficiency that Professor Ząbek presented, because it's a very rare disease. But if you put all these rare diseases together, collectively they become important. So childhood dementia in the US causes around the same number of deaths as childhood cancer. But we don't hear about that because these are all individually rare diseases, particularly affecting the brain. So we need these collective terms to address these conditions, and we need to address them on an EU-wide basis. Next slide, please. So we've got a growing international momentum on brain health. We have these WHO plans on mental health, the IGAP for epilepsy and other neurological disorders. Next slide, please. So we need European authorities to devise and implement a plan to tackle brain health. We need to highlight the argument to support basic and clinical research in Europe, and we need to optimize support for patients and research. We need to also ensure that basic research is translated into concrete applications, and we can do this at the EU scale. Next slide, please. So we should have, as many of the speakers have talked about, an EU coordination plan for the brain. And this is something that the European Brain Council, with all the stakeholders, are beginning work on. So we think about research collaboration, overarching approaches, and national brain strategies. Next slide, please. So this is a busy slide, but you can access it later, looking at all the areas in which the European Union can look at early intervention, quality of life, equity of care, workforce, carers and patients. Next slide. So we can avert the burden early through prevention and risk reduction through those critical first years of life, and then we can introduce the therapies as we've heard about. Next slide, please. So if we scale these brain health interventions, it could contribute 666 billion euros to the EU GDP in 2050. So not intervening is going to cost the EU a lot of money. Next slide, please. I'll finish there. Thank you.
Thank you, Professor. Now we start with the discussion. Vitanis, could you comment, please?
My question is the same, like in previous panel. You know, now I see reality. Brain and mental health should be as one strategy. My question is, are you ready to raise those ideas to European Commission that they can also present more or less comprehensive approach on brain and mental health, including all components, because you just have a lot of evidence that we need to move in such direction. Thank you.
Thank you. Margarita de la Pisa-Carrión.
Muchas gracias. Mis comentarios y preguntas van dirigidos a ambos ponentes, a la señora Orla Galvin y al señor Sameer Zuberi. Sí, me voy a expresar en español. Sí, nos alegra. Es el canal 8. Sí, a lo mejor ahora ya se escucha en español. Ahora, muchas gracias. Nos alegra mucho, tanto como a ustedes, que la Unión Europea haya dado este paso importante de intentar impulsar un enfoque más integrado de la salud cerebral, por ejemplo, a través de Brain Health Partnership, que busca en teoría mejorar la coordinación de la investigación entre Estados miembros, ¿no? Pero sabemos que ustedes lideran proyectos muy esperanzadores en este sentido, pero creo que ha cambiado la manera de otorgar la financiación. Lo que antes era NET o JPND, ahora se llama así, Brain Health Partnership. ¿Cómo está afectando esto a los avances de sus investigaciones en neurociencia? Al parecer, cada gobierno puede invertir diferente, ¿no? Sabemos que Alemania e Italia pues, están dando mucha financiación a proyectos, pero parece que en el caso de España pues, no es suficiente y además parece que si te presentas a un área, no en otra. Vemos esta distinción tan frecuente de salud mental y salud cerebral, dando prioridad muchas veces a la salud mental, ¿por qué nos va a preocupar más un asunto de psiquiatría, que sí, que uno de neurociencia? Por otro lado, en las investigaciones de neurociencia es muy importante la experimentación en modelos que repliquen la complejidad cerebral. ¿Cómo es importante la experimentación en animales, incluso en primates no humanos, para poder continuar avanzando? Sabemos que hay restricciones en este sentido. Están poniendo difícil la investigación previa a la puesta a utilizar estos medicamentos o estas terapias en personas. Por último, en el contexto de profundos cambios socioeconómicos, automatización y transformación de los sistemas productivos, invertir en salud cerebral es también invertir en capital cerebral, educación, creatividad, innovación y potencial humano. ¿Cómo puede la Unión Europea reflejar mejor esta dimensión estratégica de cerebro en todas sus políticas públicas? Muchas gracias.
Ignacio, would you like to comment?
I have a simple question. From what I listened and learned, obviously the brain develops from, the embryo to many years after we are born. And many of these diseases, needs several years to develop fully. In your opinion, how much are we doing in order to do regular screening and catch the disease as early as possible, giving to the patient more opportunity to recover or possibly be entirely cured?
Thank you. Romana Jerkowicz.
Thank you, Chair. I want to thank you for both presentations. It was very interesting. But I have a question for you, Professor Zuberi. If we were to set four measurable EU-level target for brain health by, let's say, 2035, what should they be? I mean, you mentioned a coordinated EU plan for brain health, and of course we all agree, but I'm sure you know that we already have an important reference point at EU level with Europe's Beating Cancer Plan. So if we consider a similar approach for brain health, then my question would be, what should we do differently from the cancer plan? Thank you.
Thank you. It was the last question, so I'd like to ask our expert to answer this question. Mrs. Galvin, could you start, please?
Sure. So the first question came around the topic of uniting mental health and brain health. And for those living with a neurological condition, they go very much hand in hand. The vast majority of neurological conditions are chronic and progressive. So over time, people with neurological conditions very often develop depression, anxiety, and financial stress. In answering the next question that refers to the European Partnership on Brain Health, again, mental health and neurological health go hand in hand. And in fact, the patient community, EFNA, representing the neurological community, and GAMIAN, representing the mental health community, very much insisted on having a patient oversight within that framework, and we're very pleased to see that moving forward. But rightly so, you have indicated that, of course, member states need to take up this challenge as well and invest and contribute and support the European efforts. The next question was around animal use in research. I'm a scientist by background, and we absolutely advocate for the appropriate use of animals in research, which is essential for neurological condition only owing to the complexity and the lack of treatments available. And in fact, many of our advocates in training attend universities to witness the advances that are being developed across Europe in this space. And if we don't have research in Europe, it will go elsewhere where it may not be as tightly regulated. I think the second to last point that was addressed to me was around the socio-economic impacts and the capacity that we have in Europe and what can we do better. Well, actually, there's a lot of talk about brain capital and brain skills and innovation and solution-orientated minds. And actually, this is something that applies to anyone who has a chronic, progressive neurological condition, who has to adjust their life, adjust their finances, adjust their family. And what we're talking about here is really the resilience of people with neurological conditions. So we have that, and we should harness the power behind that more. And the last question was around the identification of conditions early with respect to screening. This is something anyone who's an advocate in the rare disease space will know, that we don't have united or a unified approach to newborn screening across Europe. Some countries might test for 8 conditions, other countries might test for 40 conditions. And this also reflects on the need for enhanced investment into the workforce in Europe, because we need more genetic counsellors to support the diagnosis as and when they come as well. And I believe one of the harder questions at the very end was left to you.
Thank you, Professor Zuberi, please.
Thank you, and thank you for... Oh, I'm listening to myself. Yeah, the first question was on brain health and mental health together. And I think that is, or neurological health and mental health together. And I think that is critical. As a children's neurologist, the person I work with most closely is the child psychiatrist. We cannot really divide. And in Italy, you have joint training in neuropsychiatry and in neurology. So it is seen as the same discipline in certain parts of Europe. So we cannot divide the two, and I think our strategy should be to put them together, because when we we were at a rare diseases meeting today, and we heard from questionnaires of families of and individuals who have rare diseases, and they all described the hidden burden of their rare disease, and their hidden burden was the anxiety, the depression, all the other issues that are hidden away and not seen as part of their illness. So we cannot divide them. The second question was about the European Brain Health Partnership. I think it's too early to know how that will change the funding landscape, because the first calls just came out. I think the deadline for the first call is March the 10th. But what is good about the European Brain Health Partnership is that it encourages teams around Europe to collaborate together. And it also has a model of funding from the national research organizations alongside European funding as well. So hopefully that will encourage collaboration, and these are the sorts of things that the EU should be doing. But too early yet to know the impact. In terms of research on animal models, I would agree with all of the brain. And as I said, it's the most complex organism in the known universe. So it is very difficult to do scientific research and say this is reflecting the brain if you're doing it on one cell in a little dish. You have to do it in a more complex organoid. Now, that may require animal experimentation. That should be minimized as much as possible. Increasingly, there will be opportunities through organoids, which are when you can grow a brain in a dish in the lab. And we heard a little bit about that in the first talk today. So I think we will learn more because that will recapitulate the complex network of the brain. The brain should always be thought of as an interconnected network. And that's why, we need more complex models. So we need to invest in brain health, as we talked about. If we invest in brain health, we will invest in the economy of Europe as well. We know we have an aging population, so we need to keep the working population as healthy as possible and keep them working and keep them wanting to work for as long as possible. And the only way we will do that is by making everyone feel that their brain is active, vibrant, and ready for the day. And we can only do that through improving the general brain health of the EU population. In terms of early diagnosis, screening is critical. There are now more programs for whole genome screening that are beginning to be tested, even at birth. And they will teach us whether, if we do that at birth, we can prevent diseases, diagnose them rapidly. We heard about the wonderful new gene-targeted therapies that are coming in. But in order to treat those, it's much better to treat them before the symptoms appear rather than when the symptoms appear. So you need to find the genetic change first through genome testing and gene screening. So the EU needs to put in support to allow that around Europe. And then education, so that every doctor, every physician, every healthcare worker knows about the early signs of neurological disease and refers early. And for that, we need European rare disease reference networks, as we've got, but we need those reference networks to then inform national networks for care pathways. And then I've left the difficult questions to the end on the measurable targets. So obviously, we need more research investment, so we need to show that we are getting more research investment into brain. We can have the IGAP, which is the Intersectoral Global Action Plan for Epilepsy and Neurological Disorders, has measurable targets. So the targets are disease-specific. It will be difficult to have targets for all brain health. But I think you can have model diseases such as epilepsy and ensuring that 80 to 90% of people with epilepsy are diagnosed within 2 weeks, ensuring that they get the appropriate medication, are seen by a specialist. So we can measure those targets, but we need systems in place to be able to audit our clinical practice so that we can then measure and then feed back and show that we're improving. But Professor Verdelho, my last point, showed that if you have good public health interventions in some of the Nordic countries, parts of the US, you can reduce age-specific dementia. So we can prevent and reduce dementia levels if we intervene early.
Thank you, Professor. Thank you all for this discussion, fruitful discussion. I would like to thank especially our guests for the very interesting presentation and being with us today. We will share you all slides from our expert, as usual. It is clear that we have to keep high neurological health, high on the EU public health agenda. Thank you all for this good discussion. Thank you.